We'll be maybe getting more people coming in. Appreciate everyone coming. It's a nice evening, and I think it's a good day to have a conversation. Just to introduce myself, some of you know me well. Maya Safarova, I'm a cardiologist. I'm a non-invasive cardiologist with a passion in imaging. But I would say my clinical and research passion is in individualized cardiovascular prevention and, if you will, in precision lipid management. So how can we bring cardiovascular genomics to practice? And today we'll be talking about a challenging group of patients, low extremity peripheral arterial disease, mostly low extremity, patients with familial hypercholesterolemia and elevated Lp(a). Now, I would say my main disclosure would be that I believe in lipoprotein apheresis, and I've been doing research in this field as well as managing patients with lipoprotein apheresis since 2009. In fact, my PhD was using Lp(a) and lipoprotein apheresis. So you will be hearing from someone who has been fairly consistent with the management, and one of the reasons of this consistency is that I've been seeing the results, and I had a chance to practice in 3 countries, and had experience with 3 different models, and still maintain my interest in lipoprotein apheresis. Now, the starting point, I think, and to sort of get that understanding why, atherosclerosis comes in really different phases, and pathophysiology, when we think about how to structure the pathophysiology, there are 3 main pillars: cholesterol driven, inflammatory driven, and immune mediated. And we've made the most progress with cholesterol driven risk reduction. Some progress is being made with inflammation and less so with immune mediated approach. But when you think about risk assessment, mostly you use your lipid panel. You think about age, gender, race, you think about their blood pressure, but you use a lot of lipid panel. And that's since 1929, since the discovery of lipoproteins. Lipid panel has been part of this decision making. Initially, not so much, and there was a lot of controversy: should we even lower cholesterol or not? But as time progressed and more evidence, more refined evidence became available, this is something that is probably used by a wide variety of providers, including surgeons. But lipid panel, interestingly enough, is only tip of the iceberg. It's only tip of the iceberg. And there's, in addition to, which could be due to acquired factors, changes in lipid profile, but also inherited. And then the risk for the heart attacks and strokes is not infrequently something that we would call residual, when we addressed everything that we could using contemporary medicine, and we still see events happening. So that's another patient population that is amenable to having conversation about lipoprotein apheresis. Now, as of 2025, LDL cholesterol and ApoB, based on observational data, genetic data, randomized clinical trials, they've been proven to be causal. But what I find fascinating is that atherosclerosis as an entity is not a modern disease. Based on the studies, CAT scans of the mummies, it's been present more than 4,000 years ago. So despite the different epigenetic landscape, atherosclerosis is something that we still yet to battle. Let me put it this way. Now, while it is indolent and progressive disease, what we've learned is that there are ways how we can stabilize the lesions. Now, we don't know why in that particular individual, that particular vascular bed gets affected. Some of them get one bed affected coronaries or their peripheral arteries. Some of them get multivascular disease. And we yet to, there are theories and shear stress and location, but there's no good way how to predict the development. But what's important is, and this is just one of the examples that you're seeing currently, the PACE study, Progression of Early Subclinical Atherosclerosis, one of the trials looking at younger individuals, at those with subclinical disease, in attempt to see can our intervention result in not just stabilization but regression of the lesions. And it's a nice example when the answer is yes. The answer is yes. So the atherosclerosis is not necessarily only one direction. Now, peripheral arterial disease is not just a severe form of atherosclerotic vascular disease that affects more than 230 million people worldwide, but it's quite a burdensome on the healthcare system, cost-wise. And just think about the numbers. That's sort of similar to heart failure when they compare it to cancer. But the 5-year mortality associated with chronic limb ischemia without amputation is somewhere in the range of 55 to 65. Hi, Stacy. Thank you for coming. Now, PAD, the problems association with adverse limb events, as well as association with adverse cardiac events. Probably the most likely probability of someone with lower extremity peripheral arterial disease of having high mortalities because of concomitant coronary artery disease. Now, here's a clinical vignette, and this is just to give you a little bit of distraction. You have a 68-year-old who is seeing an ER, 2 weeks of constant right foot pain, and he doesn't have any trauma, so he just developed this pain. He's fairly sedentary, no consistent medical follow-up. He has hypertension, high blood pressure, high cholesterol. He has osteoarthritis as well, to mention. He's an active smoker. He drinks 2 beers per day, and he is on amlodipine, aspirin, lisinopril, and rosuvastatin 40 milligrams. So he's on maximally tolerated statin therapy. His blood pressure is 136/84, heart rate 82. Some wheezing on lung exam. He doesn't have any murmurs. He doesn't have palpable pulses in his feet, and he has ulcer on the lower surface of the second toe of the right foot. So if left untreated, which one of the following do you think would be highest risk within the next year? Would it be myocardial infarction? Would it be stroke? Would it be atrial fibrillation? Would it be gout flare? Would it be amputation? What do you think? I'm going to pick up on Layla. Amputation. You could say a minor stroke, and you might be not wrong because he is at risk. But and it sort of gave, I'm not sure why animation did not work, but patients with chronic limb ischemia, which he has here. And one thing I did not highlight was, and sort of did it deliberately, pulses were not palpable. So you start thinking about something that is limb threatening. Is amputation. And the risk is, based on the study, depending on the literature that you read, is 20 to 50%, quite remarkable. Now, the risk factors for peripheral arterial disease, because the underlying is atherosclerosis, similar to coronary artery disease. Everything that we typically think about and put together in the calculators, this is all here. High sensitivity C-reactive protein, sure. Chronic kidney disease, sure. Additional risk factors. But an important risk factor that I'm happy to see we're more and more recognizing is lipoprotein(a). Lipoprotein(a) in patients with lower extremity PAD, especially younger individuals, not just, it is a risk factor for age-wise, long-term, but especially in younger individuals. In this particular study, those younger than 50 years old, it is associated with a severe presentation and poor outcomes. Interestingly, additional risk factors that were noted in addition to smoking were low HDL level despite normal triglycerides, which is a trait that's usually genetically determined. So, for those who are on Zoom and here, it's more to think for yourself. Do you check lipoprotein(a) in your practice? Do you think about it? And I think it's an important thing. Just one of the takeaways from this conversation is to make sure that when you assess the risk in someone, preferably before that someone develops an event, we think about better ways how to stratify it. And this is a nice Mendelian randomization study that used genetic information that showed that Lp(a) particle, in fact, when compared to LDL particles, is more atherogenic. It's 6-fold more atherogenic How remarkable it is. Now you would say, well, if it is, there are a number of questions. Then why evolutionary we retained Lp(a)? Why then Lp(a) is not number one and then LDL? The thing is, we carry more LDL particles in our body than Lp(a). So LDL quantity-wise becomes more important, but quality-wise, if you think in that matter, Lp(a) is more atherogenic. And Lp(a), this is a more recent analysis, has been shown every 50 milligrams per deciliter, and I would use 50 milligrams per deciliter here just because in for instance our system, Freighter MCW, as of now 2025, we still return results in milligrams per deciliter. The recommendation is actually to move towards nanomoles per liter. So every 105 nanomoles per liter, genetically determined higher Lp(a) are associated with 1.4-fold higher risk for peripheral arterial disease. Now, this is a consensus statement from the National Lipid Association. There are a number of takeaways about Lp(a). One of the major ones that we should think about Lp(a) as a continuum of the risk. And the way that you would try to stratify it when you try to sort of convey the risk to the patient is, if it's less than 30, it's low risk. If it's more than 50, again, milligrams per deciliter, it's a high risk, and everything in between is a gray zone. Now, if you look in the data, and I'm not going to spend more time on this, it's the whole conversation to have. Data from the Copenhagen population study shows that there's already increase in the risk starting with Lp(a) at 10 milligrams per deciliter. Our early data back in mid-2000s, we showed that Lp(a) at 25 to 30 milligrams per deciliter is significant. As of now, in clinical trials that are ongoing, phase 3 clinical trials targeting Lp(a), and with lipoprotein apheresis, the target is more than 50 milligrams per deciliter, 75 nanomoles per liter. For lipoprotein apheresis, you'll see later, it's 60 milligrams per deciliter and 30 nanomoles per liter. Now, familial hypercholesterolemia, patients who have high Lp(a) frequently have FH. Patients who have high FH frequently have high Lp(a). Both are genetically determined conditions. As you know, Lp(a) is about 90% genetically determined. Now, what is FH? Just a few words. Familial hypercholesterolemia is autosomal, predominantly autosomal dominant condition that is characterized by very high LDL levels. That's the textbook definition. Now, we'll see that not necessarily very high LDL levels is an absolute need. Sometimes they can be moderate. And this is a nice example just to give you this phenotypic presentation. In case you see a coworker, in case you see a patient who has this at early age corneal arcus, which is a white rim, their eyes, if you see something that's sort of relatively profound, the deformations that xanthomas, Achilles tendon, for instance. This is an ultrasound of Achilles tendon of this 35-year-old woman. It should be 4 to 6 millimeters, and when I measured it, it was 1.6 millimeters, so quite thick. There was at one point a notion that we could do ultrasounds of the tendons to try to help with the diagnosis. So when you see that, you see some xanthelasmas, you can, depending how close you are, you can mention that they can check their lipid panel. Certainly family history pedigree analysis becomes very important in this patient population because it mostly is autosomal dominant. There are ways how we can more formally make clinical diagnosis using Dutch Lipid Clinic Network criteria. Usually it helps when you're having that information in your notes if you decide to start someone on more advanced lipid lowering therapies, just to make your point if you're making a clinical diagnosis. And from the genetic basis, this monogenic disorder is usually due to a pathogenic variant in one of the genes. It could be either due to a gene that encodes LDL receptor, and as a result, there's no binding of LDL particles to this defective LDL receptor, so you have more circulating LDL. It could be due to ApoB. It's, again, loss of function ApoB variant, which means that there's limited binding because ApoB is not being recognized by the receptor. Or famous PCSK9, gain of function, when LDL receptors are functional, normal, but they don't recycle back. And as a result, you get degradation of LDL receptors and more LDL floating. Now, this is about the levels, and I think that's very important to take away when it comes to genetic testing. This is data back from 2015 and before, published in 2016. Quite remarkable. Geisinger system had funding for 50,000 individuals being sequenced. So they had exome sequencing on these patients. And they looked at their LDL levels and just see those individuals in pink here, they did not have any identifiable monogenic pathogenic variant. And these individuals had a pathogenic variant. What an overlap. And the difference in terms of the mean, there was normal distribution predominantly, but just 70 milligrams per deciliter. So there are some patients who have LDL of 140 and a little above, and especially 160, and they're positive for FH mutation. So it could be sometimes deceptive, especially now guidelines for adults, it indicates 190 milligrams per deciliter. It's sometimes, it increases your specificity, but reduces your sensitivity, and vice versa. Some fun with the numbers. So 1 of 15 patients with severe hypercholesterolemia has a clinical diagnosis of heterozygous FH. 1 of 50 carries a pathogenic variant. But in about 20%, there's no identifiable variant, and there are a number of reasons, including the polygenic cause, including the fact that our genetic testing yet to be refined. When you use Dutch Lipid Clinic Network criteria, what we found is those who have a number more than 6, in 7% of the cases, they would come back as monogenic, and 19% is polygenic, which means that if you suspect that someone has clinically familial hypercholesterolemia and you do genetic testing, not always it's because they don't have that pathogenic variant. It's just we're not able to identify it. Now, here's animation that's not working. So what I wanted to show you here is that the FDA approved indications for lipoprotein apheresis, which is a procedure allowing you to reduce both Lp(a) and ApoB containing particles by about 80%, depending on how much you're treating, prior to January 2025, included patients with clinical diagnosis with familial hypercholesterolemia, with evident atherosclerotic cardiovascular disease, could be history of stroke, low extremity PAD, coronary artery disease, who had LDL cholesterol above 100 milligrams per deciliter. And then those who had elevated Lp(a) had to have suboptimal LDL. What we were able to achieve since January 2025 is that now elevated Lp(a) is actually a sole indication for lipoprotein apheresis in patients who have coronary artery disease or peripheral arterial disease. So if you have someone, for instance, on optimal medical therapy when it comes to lipid lowering, and their LDL is, say, 52 or 50, but their Lp(a) is 120, above 60 milligrams per deciliter, and especially if they are having recurrent ACVD events, this is an ideal candidate for lipoprotein apheresis. And now I also think it was a win that we don't need to be concerned that the threshold for LDL is, it was 100, now it's 70 milligrams per deciliter. Now, the first case, it's going to be a brief case. This is from the University of Kansas Medical Center. A 52-year-old African-American woman who was referred for evaluation of Lp(a) of 500 nanomoles per liter. So it's nanomoles per liter, so it's not milligrams per deciliter. But I would say I don't see frequently 500. It was quite impressive how high was her lipoprotein(a). And she had early onset of stroke that was ischemic stroke 10 years ago, so the age of when she was early 40s. And she had quite already advanced carotid disease. And for better or worse, someone decided to do CT calcium score while she was on statin therapy, and it came back quite elevated. So she clearly had evidence of advanced vascular aging, and she also, as it frequently happens, had a strong family history. Now, this is how her CT coronary calcium was looking. Well, you'll have to believe me that she had 3 vessel calcified starting from left main coronary artery disease. Well, this is sad. It was such a nice picture. Anyway, So she had very calcified vessels. I think it's always impressive to see some of those pictures, visualizing it, and especially correlating it with age, even though she was on a statin, which increases the chance of positive CAC score, but still it was impressive. So untreated LDL cholesterol was 196, and unfortunately she was statin intolerant, but we were able to get her on rosuvastatin 5 once a week. She then started on ezetimibe 10. Her journey was sort of rosuvastatin 5 weekly, then ezetimibe 10. She observed about 16% LDL lowering, which is on average what you would get with ezetimibe, range of 15 to 20, sometimes 25, except certain situations who are hyperabsorbers. And then she was started on evolocumab, which is a monoclonal antibody to PCSK9, and she got relatively suboptimal LDL lowering because she had only 38% on top of what she had before. And notably, she didn't have any, based on the commercial genetic testing that tested for genes, she didn't have any pathogenic variant. So if you think about this patient, her LDL is probably should be quite low. How low? Very low, less than 55. What should be her Lp(a) goal? We don't have an answer as of now, but clearly it's very high. And most of the data, both genetic and clinical data based on PCSK9 inhibitors, which have limited potential, up 15 to 30% Lp(a) lowering, and with apheresis, it shows that it does improve outcomes. But I don't have a good answer what should be the goal. The lower, the better as of now. Similar concept to LDL. Not sure why the animation is not working here. But behind this, and I think the slides will be available for review, behind this pop-up was the 22 ACC expert consensus, which takes you through the path of decision-making of thinking about lipid-lowering therapy. And what I wanted to emphasize here, which was pleasing to see, is prior in the guidelines, it wasn't mentioned, that lipoprotein apheresis should be one of the paths in those who don't achieve the needed proportion of LDL lowering and the needed therapeutic goals. So this patient, based on that clinical profile, was easily approved to receive treatment with lipoprotein apheresis, and she's currently in receiving it at KU. Now, something again that I wanted to, for back and forth conversation, just a question to think about. If you refer patients to lipoprotein apheresis, just out of curiosity, did anyone refer? Well, hopefully you will. You'll start more and more because, for instance, at Freighter, MCW, we've been growing actively the program, and right now we have 9 actively treated patients for different indications, and we have 1 who is being treated with plasma exchange for high triglycerides. Now, it's a busy slide when you don't have animation, but I would say the takeaways is some of the things about lipoprotein apheresis. Similar to cardiovascular risk reduction, the higher your baseline lipids and lipoproteins, the greater you observe relative reduction in the ApoB-containing lipoproteins. Just to reinforce, everything ApoB-containing is atherogenic. Your goal per session is to achieve a reduction in approximately 60%. With lipoprotein apheresis, you do reduce free PCSK9 by approximately 50%. And we've observed quite rewarding results with combining PCSK9 inhibitors and lipoprotein apheresis, which allows you to reduce the interval treatment between the sessions. And more and more, we recognize how much of a benefit is there in individualizing treatment based on the so-called time average. There's Kroon's formula, there are approaches how you can optimize this LDL cholesterol and Lp(a) level based on each individual's clinical profile. All right, one of the things here that I wanted to highlight again is that we don't know what is the goal for Lp(a). Should it be an absolute goal of less than 50 or less than 30 milligrams per deciliter? Should it be a percent reduction, such as, for instance, 80% that lipoprotein apheresis offers? it's yet to be answered. I think it's better to go over some of the studies rather than just to look at the table. But this is some of the, I think frequently the question that I get is, well, what is the evidence? What's the evidence that lipoprotein apheresis works in clinical settings? Sort of what is the data? This is some of the data more focusing on lipoprotein Lille and outcomes, and specifically here, lipoprotein Lille in future cardiovascular and limb events in patients with peripheral arterial disease who undergo endovascular therapy. This study comes from Japan, more than 1,000 individuals. And here they found that the Lp level above 30 milligrams per deciliter was associated with a twofold increase in the risk of major adverse cardiac events, but also fourfold increase in the risk of repeat interventions, major adverse limb events. And what is important that this was irrespective of the LDL cholesterol level and irrespective of the fact that they were on statin therapy. Now, this was also something that those who do angiograms would have appreciated the visual. This one is like main thing on the menu. This is my main case, and quite interesting with a number of concepts. So this is a 60-year-old South Asian woman who is a retired nurse herself, who was referred for the management of LDL cholesterol. Her story goes back with when she was diagnosed with claudication at the age of 48 years old. So it was early onset of the disease. And at the time, it was outside hospital. She received a bare metal stent. Not sure why they decided to stent, but she received a bare metal stent to distal left SFA at the age of 51. She was lost, unfortunately, to follow-up, and she intermittently attended this supervised exercise training program. Now, when she was 56, she developed acute limb ischemia due to SFA occlusion, and she was treated with a balloon angioplasty. And she had a gradually progressive claudication, reduced walking distance. She wasn't really able to participate in what she was at the time recommended aquatic aerobics due to pain in her legs. And on top of that, she developed a non-healing sore of the left big toe. So when she came to us, she came with a total occlusion of the distal left anterior tibial artery and dorsalis pedis. So her left her circulation, peripheral circulation, was very poor. It was a sad situation. And what we did was we did an intervention. She underwent ballooning, and successfully her arteries were opened. Based on their evaluation, there was less than 20% residual stenosis, was brisk flow, and now her pulses were palpable. So she was started on dual antiplatelet therapy with the recommendation of aggressive risk factor modification. Now, this was done by one of our colleagues at the time, Dr. Azam. And again, unfortunately, I'm not able to play the images here. Just to give you a little bit of a more of a phenotype perspective, she had a mother who had a stroke at 60. She was a never smoker. She had pre-diabetes, so not necessarily uncontrolled A1C. Hypertension, while on a statin, again, someone did CT calcium score and was elevated. And then unfortunately, she was also statin intolerant, and she tried multiple statins and developed severe myopathy, including to ezetimibe, but was able to tolerate pitavastatin. We couldn't prescribe more because of her reduced GFR. It was 50 or 52. You can see that she was not obese, and she actually used to be an avid runner. So she was someone who was watching what she eats. Again, she was a retired nurse. Again, someone who has very high Lp(a), 217 nanomoles per liter. Her untreated LDL was not available to us. But sort of the assumption was that her LDL cholesterol was 158 using coefficients to try to estimate what was her LDL cholesterol untreated. Here's an interesting part. So initially she was started on alirocumab, 75 milligrams, 6 doses, LDL cholesterol didn't budge. Well, it went even up. Okay, so we failed. We decided we will move on to inclisiran. She did 2 injections, 3 months and 6 months, and obviously was disappointed, 165. And you would think, well, maybe she started on some sort of medication that was drug interacting. No, she was just not responding. She had a history of gout, apparently, and that's why she was hesitant to even think about bempedoic acid. And then she didn't have homozygosity for FH in order for her to be potentially considered for evinacumab, which is a monoclonal antibody to angiopoietin 3, or lamiptide, which is MTP3 inhibitor. Her genetic testing was returned positive for a pathogenic variant in the ApoB gene. But then, could it be that she has other causes genetically determining her from being so resistant to therapies? Potentially. Now, she actually was very open to start lipoprotein apheresis right away. And we initiated every 2 weeks, and an average her LDL lowering was about 74%, and Lp(a) was approximately 60%. Again, the percentage of reduction really depends on how much time the patient stays with the treatment during the session, how much do you treat. So in terms of period of observation from 2022 to 2024, she didn't have any ACVD events. On top of that, there was clear healing of the left foot ulcer, and there was improvement of ankle brachial index, as well as improvement of the walking distance, almost up to 500 feet. So that's it's a case. You can say, well, this sounds like an anecdote, but I'll show you some data that actually clearly demonstrates that patients who, especially those who are not amenable for revascularization because they already had multiple interventions, or it's just anatomically difficult to do, they derive benefit from being on lipoprotein apheresis. So lipoprotein apheresis, the modality, the only modality that's available in the United States, is using dextran sulfate. And that's a liposorber machine. It was first proposed in the end of 80s, and it is not specific, it's a selective removal of ApoB containing particles. And the way that it works is that it's sort of charge-based. So there are a number of ways how you can perform apheresis. There's immunoabsorption, there's heparin-based. Dextran sulfate uses char-based approach, and it removes negatively charged particles. And the machine has 2 columns. When the first column gets saturated, usually approximately 500 ml, but again, that's something, everything is programmable. It gets through regeneration, and then the second column starts getting saturated, and the blood that is being returned is with reduced atherogenic particles. And as you will see further, not only atherogenic particles, but also inflammatory particles. So in terms of cholesterol levels, this is data from the Lipid Center in Kansas, where there, as of now, 80 patients are being treated. They have various profiles. Some of them have FH, some of them have high Lp(a), some of them have just progressive ACVD. These are the numbers that you would generally see. LDL cholesterol average 70 to 80%, Lp(a) general 70 to 80%, triglycerides are being reduced as well. Now there are 2 caveats. I'm not going to go in detail because we can open it for Q&A. But if you have someone with very high triglycerides, that can be a challenge, and there are ways how we can approach it. Challenge in terms of the access to perform the procedure adequately. And then you see here HDL cholesterol, and frequently that's a question that we're being, well, you are reducing HDL as well. Does that is that a bad thing, or is that a good thing? So we've studied that extensively, and reduction in HDL cholesterol is actually not a bad thing here, what you're seeing. We did a proteomic analysis, and as HDL is a complex particle, and some of that is dysfunctional. So mostly the HDL that's being reduced is carrying ApoC and ApoE, and as a result, that's a dysfunctional HDL that are actually being reduced. Now with Lp(a) apheresis, that a typical, or lipoprotein apheresis, that's a typical sawtooth that you would see with LDL and Lp(a). that pre-treatment is high, post-treatment is low. There are a number of things that are happening. As time progresses, the pre-treatment levels go down. And importantly, one of the ways, for instance, I explain frequently, I get asked, just even for statins, do I need to be on it long term? Why do I need to do Repatha every 2 weeks? Like, why do I need to be compliant? And that's sort of the question I would summarize it. But one of the reasons is when you reduce something that is LDL cholesterol type, for Lp(a), it's a little bit different. But for LDL cholesterol, on average, the metabolism is about 14 days that it goes back to pre-treatment levels. For Lp(a), it's approximately 10 days. So for Lp(a) pathology, actually, if you want to be proactive and sort of reduce it really, you would do it every 7 to 10 days. It depends on the patient, depends on their sort of preference, because you're balanced between compliance and between making sure that you're getting the needed outcome. Just because I mentioned this case to you that had fairly suboptimal response to PCSK9 inhibitors, both monoclonal antibodies and inclisiran, we did some more digging into what literature has been reported. And interestingly, for inclisiran, the study that was published in 2023 coming from Germany, 14 lipid clinics, when they looked within 1 year, 2021, 2022, they found that most of the patients, instead of having 40% reduction in LDL cholesterol at 3 months, had 24% reduction. And importantly, there was high inter-individual variability in LDL cholesterol changes, which just reinforces that you not just start someone on a medication, but you make sure that you do surveillance, especially within the first year. That's the protocol that we follow in our lipid clinic. For PCSK9 inhibitors, in this study published in 2020, that's a single academic center, 400 patients approximately, a little over 411, they confirmed unusual response defined as less than 30% reduction in LDL cholesterol as almost an 8%. Now, what's reported in clinical trials? It's reported as less than 1%, and it reported that there are no neutralizing antibodies. In real practice, we actually see it more so. The good thing about this study that looked at unusual responders, they made sure that those were not due to non-compliance, and they looked also into secondary causes. This is our database of 2,000 individuals who were prescribed monoclonal antibodies. We didn't look into inclisiran. We only looked at monoclonal antibodies, evolocumab and alirocumab. You can see predominantly white, followed by a Black and Asian population, almost half and half males and females, predominantly non-Hispanic, and average age being 66 years. In this EHR-based, electronic health record-based retrospective analysis, where we didn't really refine the population based on whether they were compliant, non-compliant, secondary causes, we identified up to quite remarkable 11% of patients did not have change in their LDL cholesterol when it was rechecked within 18 months after initiation of monoclonal antibodies. Another interesting aspect, 14% did not have lipid reassessment, and just reinforcing what's been reported across the country, a low uptake in Lp(a) measurements, only 6% had Lp(a) measured. Now, what makes lipoprotein apheresis unique? The first treatment was offered back in 1967 to a patient with a homozygous FH. So the history goes back decades. The experience goes back decades, safety data, clinical data. The uniqueness of lipoprotein apheresis is that in addition to lowering lipid particles, it also lowers pro-inflammatory biomarkers, pro-thrombotic markers, markers of vascular function get improved, and markers of rheology. It's sort of like one of the analogy that Dr. Moriarty has been sharing is drinking tomato juice versus water using a straw. And I think it's a nice way to think about rheology. We don't use rheology in clinical practice, but from research standpoint, it's a nice clinical outcome. Now here you see on the right side, intermediate thickness, carotid intermediate thickness of someone who is 8 years old, someone who is 40 years old, and someone who is 80 years old. And that sort of shows you vascular aging. Vascular aging that would be probably appropriate for the age, but then that could be different. There are people who are at the age of 20 years old and they have already carotid plaques, they have coronary calcification. There are individuals who are 80 years old or 70 years old and their calcium score is 0. So there's very heterogeneity in how atherosclerotic cardiovascular disease presents. Our, I think, goal is that early recognition and when need be, adequate and timely intervention that can really change the trajectory of someone's prognosis. One of the reasons I wanted to highlight the, what, if you will, pleiotropic effects of lipoprotein apheresis is that many of the current vehicles that are potent and that target LDL cholesterol or being tested for Lp(a), they do offer what they're being asked to. They antisense, for instance, a small interfering platform. They reduce the target significantly. In this recently published, just I think last month, analysis of phase 2 Ocean A dose trial that looks into olpasiran, small interfering RNA to ApoA. They showed substantial reduction in oxidized phospholipids on ApoB, and you would think that that would have direct implications on the high sensitivity C-reactive protein and interleukin-6, but it didn't. There was no change at all. And I think only probably statins and bempedoic acid, as of now that are FDA approved, have impact on inflammatory markers. Neither PCSK9 inhibitors nor inclisiran affects that. And one of the reasons I'm bringing it is it's interesting that when you look at the LPA gene that encodes lipoprotein(a), it's located on the chromosome 6. The ApoA part of lipoprotein(a), so it's mainly what makes the phenotype of Lp(a), is being modified by the expression of interleukin-6. So there's a correlation between those. It's not as well defined, but especially in the COVID times when people were checking Lp(a), it was clear that Lp(a) was elevated, was higher than prior to COVID-19. There was reduction with IL-6 lowering treatments. I want to give you a few examples of clinical trials with the use of lipoprotein apheresis. This is a randomized clinical trial using sham columns, so in a way placebo-controlled, that was performed in the UK and was looking at cardiac MRI perfusion before and after treatment. And what they found was that in patients who have high lipoprotein level, defined as more than 50 milligrams per deciliter, and who were presenting with angina, not responsive to maximally tolerated anti-anginal therapy, beta blockers, calcium channel blockers, nitroglycerin, ranolazine, they showed that there was improvement in exercise capacity and symptoms. But what was important that they objectively showed improvement in myocardial perfusion, and on top of that, reduction of atheroma burden, which was not just statistically significant, it was clinically significant. Now, this is data from our German colleagues, and they use various lipoprotein apheresis modalities, and most of what you're looking here is you're seeing ASCVD events in individuals on average about 6 years before they started the treatment, and then 5 years after they started the treatment. All of these individuals had elevated lipoprotein(a). All the treatment modalities were non-specific for Lp(a), so they were reducing both LDL cholesterol and Lp(a). But what's remarkable is that drop in the adverse cardiovascular events per year. There's substantial reduction in the event rate for myocardial infarction, for stroke, for the need for repeat coronary stenting, for the need for coronary artery bypass surgery. This is another study that was published several years after, that was looking 2 years before initiation of therapy and 2 years after. And again, patients with elevated Lp(a), you can see that mean Lp(a) was 105, and LDL cholesterol was only 99 milligrams per deciliter before they started the treatment. An average 60% reduction in LDL and 70% reduction in Lp(a), and dramatic drop in event rate, dramatic drop in event rate. So it's, you know, the harder, it's hard to get closer to hard outcomes than this. Now, the limitation downside is that this is not placebo controlled. However, for an individual patient, what matters is that when he starts she starts treatment, they don't need any more to see their interventional cardiologist or CT surgeon. This is a recent data from 2024. That's a registry-based data using 11 years of observation, more than 2,000 individuals, LDL approximately 70% reduction, Lp(a) approximately 70% reduction, and they looked at adverse cardiovascular events such as death, acute coronary syndrome, bypass surgery, and coronary stenting. And what they found was the interesting aspect, they divided patients based on their LDL and Lp(a). And if you would, you would say that, well, I expect that if someone has high LDL and you reduce it, you have event rate reduction. What was also supportive here is that someone who had low LDL cholesterol and high Lp(a) had substantial event rate reduction. And this is just one of the examples of why new FDA-approved indications are so important for patients, especially those with progressive atherosclerotic cardiovascular disease who have elevated lipoprotein(a). Specifically focusing on those with lower extremity peripheral arterial disease with stage 2B and above, those with who underwent recent revascularization and had Lp(a) levels above 60 milligrams per deciliter. In this study, their protocol was to do weekly lipoprotein apheresis for 12 months, and then for the next 1 year to do lipoprotein apheresis every 2 weeks. Remember, I told you that the best results you get when you do weekly lipoprotein apheresis for Lp(a). So they did this protocol of 2 years, and they looked at outcomes of ankle brachial index. They looked at partial oxygen pressure. They looked at pain level, and they also looked at the walking distance. It was quite an impressive change in all those outcomes. Now you see the numbers are certainly not comparable to the numbers in the Fourier trial, which was with evolocumab, or Odyssey outcome trial with alirocumab, where when they had more than 10,000 individuals. But I would say numbers in these type of trials should take into consideration the number of treatment sessions, because for each individual, the number of treatment sessions becomes more than 50, more than 100. So it is not easy to conduct these type of clinical studies. Another study that was published in 2024, the Let's PAD study, that screened 72 individuals and ended up analyzing 30 patients. Take a look at their lipids before they started the treatment. Their LDL cholesterol was on average 77 milligrams per deciliter. They had low C-reactive protein. They had fairly reasonable lipid profile. I would say average for what we see before we further optimize them. And then what they looked at was specifically changes after 10 sessions of lipoprotein apheresis. And they found substantial improvement in ankle brachial index after 10 sessions of lipoprotein apheresis. This is carotid arteries, but what I found interesting is a few things. So this was coming from the Netherlands, to my recollection. And what they did, they looked at patients with familial hypercholesterolemia, and then they looked at patients who normal lipidemic patients, and they did PET-CT of their carotids, and they clearly demonstrated that patients who had high cholesterol levels monogenic FH, they had increased inflammation of the plaque. So the plaque was inflamed. And then what they did was they started treatment of patients with FH with lipoprotein apheresis. Those who were naive to the apheresis, they did weekly treatments for 8 weeks. And then they performed PET CT. So they performed at the baseline, and then they performed it 3 days after, on average, 3 days after the last session. And what they found using PET CT was that there was substantial improvement in, so under this demographics is substantial improvement in their parameters of inflammation. Now, lipoprotein apheresis over the course of the decades has been studied, as we talked about, focusing on such outcomes as myocardial infarction and stroke, looking at carotid intima media thickness as a marker of vascular aging. It's been studied and shown improvement in patients who have microvascular dysfunction, who have, for instance, positive stress test, refractory angina, but normal coronary arteries. Low extremity peripheral arterial disease. It's been even shown to reduce the risk of cardiac allograft, cellular cardiac allograft rejection in heart transplant patients. And those who were treated post-bypass surgery, increasing the patency of the grafts. Interestingly, both arterial grafts and arterial and venous grafts. Now, this is our proposal in terms of the approach, sort of similar to what 2022 ACC pathway recommends, but more focused towards those patients who have progressive ACVD or those at high risk on a statin therapy for secondary prevention, clinical or genetic FH with difficult to control LDL and LDL above 60 milligrams per deciliter, how you can sort of approach the decision making to come to lipoprotein apheresis when it's the time to consider referral to lipid clinic and consider lipoprotein apheresis. I want to emphasize that it's an effort to have a lipoprotein apheresis program. It requires a multidisciplinary approach, certainly between the providers who are involved in treatment. Nurses are integral part in the treatment, coordinators, and either, let's say, endocrinologist/cardiologist, lipidologist with an expertise in transfusion medicine, or a collaboration between a lipidologist and a transfusion medicine specialist. Certainly important to have that conversation, shared decision-making with the patient, setting the expectation, opening the curtain in terms of how the procedures look. There are patient groups, which are very helpful in terms of just getting insight. There's this fear of, I'm going to start hemodialysis. And that's absolutely not the same. While it sounds that both are extracorporeal methods of treatment, but prognosis, treatment experience, the way that you feel after the procedure is very different. And I think it's important to recognize. Now, do we do apheresis, or are there experiences with apheresis in patients on dialysis? Yes, there's sometimes even sessions when you do dialysis and then you do apheresis. But in terms of patient experience, it's very different in terms of having it dialysis, and I always try to emphasize that there should that should not be an association. Now, I think we're coming to the end of the session now, and I'm at the end of the hour, so thank you for your patience. I cannot finish this conversation without mentioning ongoing efforts. You know, we're talking about, most of this talk was focusing on lipoprotein, low extremity peripheral arterial disease, those individuals who have FH, and just to reinforce, in order for someone to be eligible for lipoprotein apheresis, you don't need to have a genetically confirmed FH. It could be clinical diagnosis. Clinical diagnosis of FH based that someone has a family history, personal history, progressive ACVD. So clinical diagnosis is sufficient. Genetic testing is important, but there's still flaws with genetics testing. We always perform it, but then depending on the outcome, we sort of make a case. Now, vascular disease can come in different flavors, and I want to mention ongoing work with a multi-site clinical trial that we're working on patients with severe forms of preeclampsia. As you know, preeclampsia, the pathophysiology is quite how should I say it? It has a number of pathways involved, and mostly it's a vascular disease. Mostly it's a vascular disease. So in patients with severe preeclampsia who with severe features, nowadays we say severe features, who get admitted, who require admission between 23 to 32 weeks of gestation, and that includes those with hypertension, proteinuria, so all the severe features for preeclampsia. We plan to do lipoprotein apheresis approximately twice per week that would be continued either up until they deliver or until 34 weeks of pregnancy, whichever comes first. This is a study that not necessarily is novel. It's been actually shown that lipoprotein apheresis in patients with preeclampsia with severe features improves maternal and fetal outcomes, and on top of that, reduces the neonatal mortality. But those studies were conducted in Europe, and there are no studies that were done in the United States. So what we're trying to do is to show that there's a way how we can prolong the pregnancy and improve outcomes in mother as well as in the child, improving even the NICU admission, NICU stay duration. So if anything, two things out of this talk, my thoughts and sort of when my patients come, I sometimes get referrals because someone has a very low LDL cholesterol. But my approach to LDL cholesterol and thought process is as low as reasonably achievable. I want you to take away from here that lipoprotein apheresis is safe. And it's an effective procedure to lower atherogenic lipoproteins, in addition to atherogenic lipoproteins, to improve vascular markers, which translates into improving patients' outcomes. And specific to this talk, outcomes in patients with lower extremity peripheral arterial disease. And now I think I should have emphasized earlier that this is a talk that all of us can get CME and mock credits, and I'm going to leave this on the screen here for you that you could afterwards be able to go on this website and then just get the credit. Now with this, I'm going to say thank you for your attention. Either the ambience or I was good, but you were a wonderful audience. Any questions? Anything that sort of comes to your mind? That was a lot of information. It was a loaded talk. But the problem when you have someone who's passionate about something is that you have difficulty not to talk about something. It's like you want to share things, and I can't tell you. I had to cut this like I cut more than 30 slides, and I was like, well, there should be limits. People should not be choking on this. But there's so much you want to talk about, and you sort of you want to convey the certain message to have evidence behind it, not just to say, I am an advocate, but why? What prompted you to do that? And I think one of the things that impressed me at the time when I just started, so it was 2009, and I remember having my first patient going through lipoprotein apheresis. It was a man who had a bypass surgery, who had repeated coronary stenting, and had difficult to treat angina. He was in his late 60s or early 70s, and he was a farmer, and such a, it's great to have one of your first patients, someone who's very open, someone who is very sort of discreet, and someone who wouldn't come to seek for medical attention unless they're dying. So he was sort of that kind of guy, and we started him. His medical literacy was not necessarily at the level of he would go into conversation like this. Sometimes, our patients sometimes do like to talk about what are the markers and what is the interplay. But he trusted his health, and we started him on apheresis. And I remember that after we started and I was seeing him, he would sort of, I feel rejuvenated. And it still resonates with me, because after that, certainly there were patients who would say that, I feel fatigued, and everyone has, sometimes there's some hypertension. It's important also when you have a patient like protein apheresis that you would discontinue their ACE inhibitors and switch them to ARBs, for instance, because there's a risk of hypertension. So that's an important thing to keep in mind when you're pre-screening someone, and that's the bradykinin pathway. But he's this enlightened face. He lost weight. He was enthusiastic. He was compliant. He never missed a session. He was like a student coming, and sort of after that, I was very much in tune to screen, to call, to invite. And we were inviting for a study that was focused on elevated Lp(a). And at the time, no one really thought that lowering Lp(a) should be considered. So it was an interesting adventure for someone to sort of risk their career with a trial like that. But I'm happy we did that. And again, that the words "I feel rejuvenated" is something that I kept thinking about, and just seeing how he felt. And it could be subconscious frequently, the way that we explain things, the way we convey things. It could be that that's how he was perceiving it. But he was doing very well, and he was feeling actually much better. We were able to cut down his anti-anginals. And I've been someone who's been taking care of him for 5 years. Any questions, folks? Steve.
Really great talk. It was really comprehensive. I learned a lot.
Thank you.
I always kind of think from the patient perspective when I'm talking to patients, like what questions are they going to ask me? So could you talk a little bit about from the patient's point of view, like, so you mentioned usually it's once a week that they're going in, like where do they go? How long will they be there? Like what can they kind of expect when they're—
Superb question. So in the state of Wisconsin, we have only one location where we can offer lipoprotein apheresis. They don't do satellite clinics at present. Maybe it's the number of patients that we're treating, but as of now, it's Versity that collaborates with us, and the treatments are being offered in the infusion clinic. So as of now, it would be MN elevators for those who are familiar with Freighted, and you go to the second floor, and then the infusion clinic. And at present, the space is that those are individual rooms. They have TV, it's spacious, there's recliners, there's a spot for a significant other, for instance, if someone needs to bring. I have actually a patient with severe form of OCD who does not appreciate when you touch her. I remember we had a conversation, like I had to put gloves on, and I was telling her, like, like it was like taking an exam. It's like someone is watching you, so you're telling what you're doing, how you're doing. So that was that sort of thing while we were at the beginning, and it was just working on the trust. And we had a journey with her as we were up titrating her. She's a compound heterozygote FH, and she thankfully hasn't had an event yet, but she has a calcium score that's positive. And we gradually got her on maximum tolerated lipid-lowering therapy, and her LDL was still not controlled, and she had elevated Lp(a). So we went of this concept of what she would expect with lipoprotein apheresis. And I described her, that this would be what room it would be. She can bring the laptop, she can bring a magazine, she can read, sort of she can relax there. It's going to be warm. She will need to go through the process of vein assessment. So we're trying to maximally use peripheral veins, usually IV here and IV here. Unfortunately, especially those who are older, but not necessarily, it varies, really varies, might not have those veins. So what we do is power ports. So they would have power ports here, and the way that and we have to work with IR, the way that they place it, usually aesthetically not displeasing. So if someone likes to have open dress, for instance, for women, it might be important. They're able to place them either on one side or on both sides, depending on the anatomy. But you need 2 ports. You need 2 ports if you do ports. Now, there would be IV access assessment. The procedure, the way that I have a conversation, it depends on the indication, but on average, it's every 2 weeks. Now, I have a patient who does it every month. And she is on, she has a statin intolerance, but she still was able, we sort of negotiated statin once a week. She's also on evolocumab. And with evolocumab and lipoprotein apheresis, we're able to maintain very low LDL cholesterol and relatively lower Lp(a). Her Lp(a) was very high, and we're sort of half. It's still above 50, but we're half from what she is pre-treatment, half from what she was before, and that's with PCSK9 inhibitor. So it's also a conversation that we would start probably doing them frequently, but that as time progresses, depending on your metabolism, depending on your pre-treatment levels, and also what additional therapies there, we can reduce the number of treatment sessions if that's the burden. Because there's some people who enjoy it. They come it depends. Some are retired, some have engagements, some sort of think, okay, how I'm going to combine it with my work. So what does it mean for me? On average, it means half work. It's usually work week. We don't do on the weekends, not as of now at least. And it's a half day approximately. Now in Kansas, we were doing the procedure within 2 hours. Here, it takes up to 4 hours. And I think that the team here is trying to do the most diligent work, and they're doing the procedure slower. So they do it slower to minimize any potential hypotension, maybe. So it varies. But again, in Kansas, for instance, there were 80 patients, and the nurses, there was the whole unit for apheresis. It was a kingdom. It was a person who was ruling the kingdom. There were certain ways how it was going, and I think it was very effective in working for patients in that regard. But I think it's working for us as well, because I do have some patients who have intolerance to everything, despite the college try, and they don't have anything on board, and they're only on lipoprotein apheresis. And I have those who are maxed out on what they could tolerate, and they do lipoprotein apheresis, and that sort of also is taken into account. Now, if someone is, for instance, if I were to counsel someone who has progressive ASCVD and they have high Lp(a), I would encourage them to do it more frequently, just because the intention is to reduce pre-treatment Lp(a). But if it's something more sort of mixed and LDL driven, not necessarily as progressive, then probably it's okay to do it every 2-3 weeks, and as I mentioned, even every 4 weeks. It's always a negotiation of outcomes versus compliance and how to work through together. But those are some of the expectations: IV access, imagining how the room looks like, individual nurses. It's a very friendly environment, and nurses make you feel comfortable, and you can sort of bring your music, bring everything that sort of you would feel like it's your room, and and you're not necessarily exposed to, for instance, because at university they do blood collection in terms of cell identification. It's not like you're being exposed to hem-onc patients, which can be distressing to, let's say, someone who has certain experiences and doesn't want to have that. So they are not going to be exposed to that.
Okay.
I think that's one of those key aspects in terms of, even if you think about referring someone, right, how do you start that conversation?
Yeah.
Why would you do that? So you give that background of why we even need to be worried about your levels. In my practice, it's a little bit easy because frequently people who come to see me are motivated. they already know they need to be treated. I think there's a large gap in those who need to be treated and who are unaware that they need to be treated. So that's a yeah. But the beauty being an academic center and being in a place where you get those referrals is that someone already thought about it, and it's more about having conversation. Do I have some people who say, you know what, let's just not even bring this up for now? Yes, I do. But then, interestingly enough, as time progresses, as they see their progress, they sometimes say, okay, let's just reconvene. What are you talking about before? What are those options? And I do have a smart phase that I put in there after visit summary that they can also read again and think, and then if need be, we can talk more. And as I mentioned, there are patient groups, so they can tour the facility before they finalize decision. In any case, they need to have their vein assessment. And they're also patient groups where they're really strong advocates who can share. And some of those individuals with FH, they drive like 100, 200 miles sometimes for their treatments, because those even though with, let's say, with evinacumab for homozygous FH, you can get 30 to 40% reduction. You need to come every month for IV injection. With limitipibe, your liver can get really affected. But again, it's also about 30. Nothing offers what lipoprotein apheresis offers in terms of the percent reduction, except those newer, let's say, small interfering that are being tested. But as you know, Horizon trial that was supposed to be reported with LPLA was supposed to be reported in 2025 is delayed because of the event rate. So they're delaying it till 2026. And if it comes back, let's say, neutral, I'm sure it's going to be disappointing for many people. But what I'm going to emphasize that the platform matters. How you reduce something matters. Not everything that reduces LDL, as we know from fibrate story or from niacin story, is associated with better outcomes. Now, when they were monotherapy, potentially in certain patient populations, but not everything that is capable of lowering is necessarily translating into low risk of heart attacks and strokes. And I think it's worth recognizing. It's hard to beat like 80% reduction of event rate. And again, it's atherosclerosis. I started with pointing out atherosclerosis is a complex condition. It is lipoprotein driven risk, but not only. Having something that addresses multiple pathways, that's probably the most comprehensive way. Certainly, it is annoying that this might be more invasive that we would want. It's easy to get a treatment at home, but I think at present, and that's why it survived decades. It survived decades and has been some countries. In some countries, it's more popular. There's a very well-funded niche for that, and in some countries, it's less. But I think having that expertise, experience, and infrastructure and capability is an important piece of a comprehensive cardiovascular prevention program.
Yeah, absolutely. You mentioned with